Artificial intelligence is rapidly integrating into the entire continuum of cancer care, from early screening algorithms to highly complex treatment models. Yet, a severe disconnect exists between an algorithm's high accuracy in an isolated clinical trial and its actual value for money in a real-world hospital. Policymakers weigh a new tool's clinical benefit against its cost and standard of care. The foundational metric is the CALI, length of survival multiplied by quality of life. Dividing net cost by CALIs gained creates the ICER chart, establishing a strict line of societal acceptance. If a highly accurate algorithm pushes costs past the standard of care without delivering a proportional gain in CALIs, it is mathematically designated as not cost-effective. To determine if machine learning can actually pass this threshold, we must track its economic performance across all 4 levels of the health production model. Algorithms are not magic bullets. They represent a complex integration challenge that must perfectly interface with human clinical workflows. Technological brilliance means nothing if an innovation bankrupts the healthcare system or fails to deliver measurable, real-world benefits to the patient. The first level of the health production model focuses on keeping people healthy and proactively preventing cancer before it starts. Interventions in this space currently rely on digital coaching apps, interactive websites, and AI-driven conversational agents. These systems are designed to target and alter modifiable risk factors, tracking metrics related to unhealthy diets, UV exposure, HPV, and tobacco consumption. The algorithms drive behavior change through psychological mechanisms, setting clear goals, providing frequent feedback, and pushing highly tailored recommendations. In practice, these interactions often fail to meet clinical expectations. Participants frequently describe AI conversational styles as unnatural and the content as too simplistic to be useful, which directly hampers long-term patient engagement. This chart plots the current economic data gap. We see a massive spike in app development, matched by almost zero long-term, real-world evidence proving these promotional tools reduce cancer incidence or save money. The World Health Organization classifies health promotion as a best buy, but investing public funds into AI prevention without concrete economic evidence is a significant financial gamble. Level 2 moves the focus to early detection, relying heavily on screening and biomarker technologies. The Swedish MASSI trial for mammography stands out as the best-case scenario for diagnostic machine learning. This chart illustrates the clinical triumph of that study. Compared to standard double reading by human doctors, the AI-supported group yielded a 24% increase in the detection of invasive cancers. Economically, it achieved this high accuracy while reducing the radiologist's workload by 44%. But isolated diagnostic accuracy can easily trigger a cost-effectiveness reversal when deployed improperly. We see this paradox clearly in recent systematic reviews of AI lung cancer CT screening. On a purely technical level, the algorithm wins. AI-assisted analysis is cheaper and identifies nodules far more accurately than a human radiologist working alone. This flowchart tracks the collapse of the clinical pathway. High algorithmic sensitivity generates unacceptable false positive results, forcing unnecessary secondary surveillance. The resulting expenses, combined with a severe drop in patient quality of life from anxiety, ultimately causes a negative impact on overall CALIs. An algorithm's ability to see better is economically useless if it triggers a cascade of false alarms that drains hospital resources and harms the patient. Level 3 involves the active treatment of cancer and its ongoing follow-up. Here, multimodal AI clinical decision support systems are deployed to synthesize vast amounts of electronic health records, genomics, and complex imaging data. By calculating non-cancer factors like geographic region and patient frailty, these models are exceptionally accurate at predicting survival times and adverse outcomes. This diagram maps a Markov model study for locally advanced rectal cancer, comparing standard of care against an AI predictive pathway. The conclusion is definitive. Using AI was economically dominant. Over 10 years, the model saved €2,500 and gained 0.32 CALIs per patient. Moving into the follow-up phase, AI-powered remote patient monitoring systems, or RPMs, take over. RPMs track patient symptoms in real time. This allows clinicians to intervene early, preventing severe drug toxicities and forced treatment interruptions. These systems secure their economic value strictly by reducing expensive emergency hospital admissions and allowing for highly targeted precision medicine. The fourth and final level focuses on patient support when cancer is no longer curable. AI models consistently outperform human clinicians in accurately predicting short-term mortality timelines among palliative patients. This precise forecasting allows hospitals to remain cost-effective by allocating highly specialized, resilient-strengthening psychosocial support strictly to the patients who require it most. But assuming these tools will seamlessly map onto human hospitals is a theoretical fantasy. In reality, integration is plagued by severe operational pitfalls. Models are frequently trained on biased datasets. Algorithms operate with total opacity, and data collection consistently violates patient privacy protocols. The human cost to the healthcare workforce is severe. Automation bias sets in, clinicians rapidly descale, and the essential human-to-human interaction is degraded. Current health economic evaluations also frequently overlook systemic expenses. Upfront capital expenditures, massive software integration costs, and ongoing IT maintenance are routinely omitted from the final calculations. An algorithm is economically worthless if clinicians do not trust it, or if forcing it into the workflow shatters the hospital's operational budget. AI holds undeniable potential across all 4 levels of oncology, but high processing accuracy on a computer does not guarantee value for money in a physical clinic. To bridge this gap, health economists are proposing the value of innovation and partnership model. Under this framework, public payers provide temporary reimbursement to promising technologies, effectively giving the developers the benefit of the doubt. This diagram demonstrates the strict condition of funding. The AI tool must be embedded into live clinical workflows to harvest real-world evidence. This feedback loop is the mathematically sound way to capture integration costs, workflow disruption, and long-term CALI impacts. Technology must be engineered to facilitate human clinical workflows, not dictate them. The success of algorithmic oncology rests on the measurable, real-world extension of human life and the preservation of quality care.